So that didn't take long. We had a conversation this morning about me being more present in your social media feed. So here we go, a couple lives in a day. Like I said, if you don't like it, you can unfollow. Stay connected, but unfollow. So someone just asked about Ehlers-Danlos syndrome. And if you're still a student and you're not familiar, the diagnosis of Ehlers-Danlos syndrome, or EDS, is a connective tissue disorder, typically genetic, comes in different shapes and sizes. It matters for a variety of reasons. If it's vascular based, then obviously people are more prone to aneurysms and things like that. If it's in your ligaments, then obviously this matters a lot for chiropractors. And I want to talk about this case and what to do about it clinically. But first, I'll tell you a little bit more about why it matters. When you look at disafferentation theory, when you look at the fact that the brain is constantly subconsciously perceiving and attenuating the proprioception of the entire body, then if someone has ligament laxity, they're going to have joint instability. And as chiropractors, we typically think of joint fixation as being sort of like, the big scary monster that causes all these problems. But one of the things that I learned in the Diplomate process years ago, and that I've learned through taking care of a lot of instability cases, is that hypermobility is just as bad, if not worse, for the nervous system as hypomobility. And so a lot of these instabilities, Ehlers-Danlos cases, are also the types of cases that tend to have dysautonomias, anxiety, pain syndromes, things like that, because their nervous system is constantly being barraged with often asymmetrical, inconsistent, afferent input. So it's very noxious, very negatively stimulating. So they need us. They need help in a lot of ways. And I got a text recently from a doc who practices upper cervical knee chest, who has a pretty severe case, and wanted to know if we require an upright seated MRI study prior to starting their care. So upright MRI is really nice. You can even check the ligament integrity through end range of motion studies on an MRI. In our office, we do Blair, and we do three-dimensional CT scanning that I'm sitting next to right now as I make this video. So I feel like a lot of these cases, first of all, have already had MRIs done by the time they see us, so we can review those. And I feel like our analysis and our quantification of the subluxation is reliable, valid, and of high quality in and of itself. If we needed motion studies, then we would apply that to everybody. If we don't need them, then we don't need them. Now, they're nice, they're extra, and I might even do it if I did an end range technique like knee chest or a full spine HVLA technique. But because techniques like Blair and the maybe even a gentle toggle or orthogonal work is so gentle, and because the patient is in neutral posture when we adjust them, then the best imaging for me to see is a neutral posture image. Now, there is one caveat that I do in EDS patients. Because of the instability, I'm going to often withhold the drop mechanism, and I'm going to reduce the HVLA to the point where often we will use an instrument, an upper cervical instrument like Orthospinology's KH2 instrument. This way, you're starting, and it depends on the case, but you can start with the least invasive, almost like NUCA, where you're starting and you're slowly increasing the adjustic thrust until that subluxation resistance kind of gives way. But because I'm not trained in NUCA, and I don't pretend to be, I'd rather use the KH2 instrument. We derive vectors from our Blair analysis, and we start with that. And we only increase to the drop mechanism or to the Blair torque and toggle adjustment if they're not clearing well. But if they're clearing well with these super gentle procedures, then there's really no additional imaging needed. And so that's what I'd recommend for those that are dealing with these Ehlers-Danlos cases. They desperately need our help. They're like Arnold-Chiari cases, and very often Ehlers-Danlos has comorbidity of Arnold-Chiari. So just a little clinical insights, little clinical conversations. Feel free to reply if you've got some additional questions related to this topic or any others. All right, guys, I'll see you around.